So now we're going to move on to some of the case presentations, and thank you to all the participants for submitting cases. We had some really hard time trying to decide which ones to talk about. There were a lot of really excellent presentations. So you'll see here there's going to be a lot of probably difference of opinions from the different participants, different faculty about how to approach things. So I'd like to start off with Will Sheppard.
All right, cool. Thanks for selecting this one. So this is a 59-year-old male. He has some history here in terms of substance abuse. He's got an A1C, though it's less than 8, and he has Hep C. He presented initially to us, in a standard fashion. We saw him in clinic. He had mild myelopathy. MGOA scores were okay. And based off of some literature, we decided to watch him for some time. Turns out he comes back with acute worsening of myelopathic symptoms. He didn't have any falls or anything like that before that week. So 1 to 2 weeks before this, he lost his dexterity in his hands. He started getting some coordination issues and started to fall over. Past medical history is listed above. Past surgical history, he had a couple of cardiac caths, gastric bypass, and he's missing some toes. As far as his other history, he used to smoke cigarettes, but it was a long time ago, and he occasionally drinks beer. Medications, he is on some thinners and has allergies that we weren't planning to have any issues with. He was intact, so there's no central cord or anything like that in terms of his motor function. He did have positive Hoffman bilaterally as well as inverted reflex. He didn't have any sustained clonus or upper motor neuron signs. And he did have that generalized numbness to the hands that people oftentimes would describe. My hands don't feel like their own or I'm sitting on them. That's kind of his description. So these are the images I got overnight, essentially showing the alignment. The patient is lordotic neutral. We went over the various different parameters that you can use from the C2 to C7 lordosis or the K-line, and et cetera. And essentially at this point, I'm starting to think, okay, let me get some advanced scans and see what's actually going on here with this myelopathy. So got a CT scan. And on the CT scan, essentially, there's this ossified yellow ligament component that's shown down there, which was interesting. I'd never seen that before, so I'm glad I got the CT scan. But in addition to that, it showed some areas where I was concerned whether or not I'd be able to go to C2 if needed. So for me, it seemed to me, at least on the left image, that the foramen was high riding, and it might be difficult, as some of the presentations alluded to get into appropriate fixation, at least on one of the sides. And so after that, I wanted to get the MRI. I got the MRI. This is just showing one axial cut at the most stenotic region where that ossified yellow ligament was. And there's multiple different levels of stenosis, essentially here, compressing from C3 down to C7.
So before you move on to what you did, what are the options? What went through your mind in terms of what approaches to choose for him?
Yes, sir. So at this point, it's a neutral lordotic, in my opinion, lordotic alignment. I'm thinking most of the issue here is maybe there's some congenital stenosis. I didn't quite measure it, but I can go back and do that. But there's essentially compression from posterior. So you can do a laminoplasty, as Dr. Schaffer alluded to. You could do a laminectomy infusion. I didn't think that going anterior here with multiple levels would be the appropriate choice. So I was between those two options at this time.
And so he came in through the transfer center because of
acute on chronic myelopathy.
Myelopathy. So what's the timing of surgery? I mean, he said he's had good strength. He had Hoffman sign, had some numbness and tingling in his hands. Acute on chronic process. What was your thoughts on timing, or any of the faculty? But what's the timing of surgery here?
Yeah, he was already at this point going to be admitted, given the frequent falls. So since he was coming to our service, we figured we'd do it that admission, but we didn't plan on doing it emergently or anything like that. So essentially we talked to the OR, so asked if they had availability. We got lucky, and it was the same day.
Does the fact that his medical background, alcohol and drug abuse, does that factor into timing or decision of what surgical approach for him?
Yeah, absolutely. Tox screen was negative, thankfully. So he hadn't done any vendors recently. And essentially, the medical team was very responsive. It's a level 1 trauma center. We got them to clear the patient pretty quickly. They didn't want to echo or any other things.
But also, probably, if you said this could be done not emergently, we can bring him back to clinic and do this semi-electively. Probably some concern whether he shows up.
Yes, exactly, but also whether or not he would keep falling. He had 1 to 2 falls within that 1 to 2 weeks, so we didn't want to send him out. If we were going to delay it more than a day, we were just going to kind of keep him, watch him, and then maybe get it on the books for our scheduled days.
Okay. So maybe ask some of the other, a show of hands, how many people would treat this posteriorly? Good. Anyone, so how about if we talk about the laminoplasty versus laminectomy, since he still has his lordosis, versus laminectomy and fusion? How many would say laminectomy? Or one?
Laminectomy and fusion.
No, just laminectomy.
Oh, sorry. I was wondering why I was the only one.
I thought the same thing. I was like, ugh,
Yeah.
you guys are going to be shocked.
I mean, I've moved towards laminoplasty, but I think laminectomy in general for someone who has normal lordosis is, as long as you're not exposing the facets and you're keeping a very narrow exposure, is a reasonable option.
So I have a question. If his A1C was 13, would you still go posterior?
That would not be ideal, but I mean, you're going to go anterior for all these levels?
Yeah. Okay.
In my hands, I wouldn't feel comfortable with a 4-level ACDF. I'd try to optimize as best as I could, and just make sure the sugars are controlled after I went posterior.
So what do you think about that? Yeah, your work is, you've done a lot of work on this, and given us a lot of insights over the years.
I think, every center's different, every environment's different, but I think if you've got a patient like this with a hemoglobin A1C of 13, I think, you get the medical service involved, and this is not an emergency case, and you get that thing down to 7.5 or better.
That would take 3 months, right?
Yeah, 3 months.
Well, it's not an emergency, and I know he's falling, but I still don't think I would do an operation for somebody that was not an emergency with a hemoglobin A1C of
So what if he
13.
had central cord?
Yeah.
Oh, he came in with central cord with A1C of 13.
Well, then he just has to be done.
So posterior still?
Yeah.
I think you're balanced, right? Posterior, you're going to have your infection concern is where you're driving, right?
Of course.
But anteriorly in a sick post with
Yeah.
terrible A1C, you're going to have non-unions, dysphagia, right? The list keeps going on both sides. So
Yeah,
I
I think-
actually would agree. Like in a guy like this, if he was really ill, but he was neurologically intact, again, I get that he's myelopathic, but he's intact. I'm probably not moving on him right away. I'm
Yeah.
probably watching him for a bit. But I agree. We also tend to say they're on call. They may not be the most socially stable individual either, and so it's really hard to sometimes manage these on that elective basis.
So if you're going to delay it, are you going to put him in ICU with mat bowls? Just submit him?
If you're going to delay it weeks, you could put him in a collar, and it may stop his decline by just
Could help a little, right?
immobilizing
Yeah.
him.
Agree.
All right, so his hemoglobin A1C is not 13, and we're going to go to surgery. So we had one vote errantly for laminectomy. So how about laminectomy and fusion for this patient? So a smattering versus, and how about laminoplasty? So it looks about 2/3 laminoplasty and 1/3 laminectomy and fusion. So why don't you tell us what you did?
Yeah, so this is kind of the stuff that I was thinking of. And the thing that I wanted to kind of focus on was that ossified yellow ligament. Met all the parameters for a good laminoplasty. I was thinking laminoplasty. That ossified yellow ligament concerned me, though. I figured if I was going to raise it and it was going to tear something, I might not see it, and then I might close thinking everything's good and then have a problem later on. So I figured at that point, might as well just consider a laminectomy, and if I'm doing a laminectomy at that one level, might as well just do a lamifusion. So that was kind of the thought process there. I didn't want to go C2 because of the difficulty in the placement of the fixation, nor did I think you needed to necessarily get up there. Didn't want to take all of 3 off. I thought you could dome it. So essentially at this point I was C3 on down to T1 because I wanted to cross the junction even though the T1 slope was reasonable. Laminectomy of 4 to 7. So this is what we had intra-op. All of it is freehand technique, and just burred the facets, put some bone graft in there, didn't use BMP or anything like that. And of course the post-op x-rays don't look as nice, but he was fine. Got discharged in post-op day 6. It took some time to get him mobilized, and he's doing pretty well right now.
Anyone Any thoughts from faculty or do anything different?
I think with laminoplasty, that's going to be your open side, right? If you want to do laminoplasty there, you can see what's going on with if you get to go probably a little slower. You can't just force it open with your thumb, but I would say don't underestimate the visualization. You can still get on a cord on the open side of the laminoplasty, and at least the ones that I removed, I always worry about that, but I have not seen horrible dural adhesions from those like we think about maybe with OPLL.
Does your institution routinely perform laminoplasty or more so laminectomy fusion?
Laminoplasty. Cleveland Clinic, we have a lot of guys who love it over there.
More so laminoplasty. And you're a fellow or you're a
Yes, sir.
You're a fellow now.
So, one of the things we think about in a sick host, right? Think a little bit about the demand for healing. There's obviously the soft tissue concerns that we talked about. Arguably, they're the same, although I think you can also argue that they're probably less for laminoplasty. But overall, I just think the biological demand that you're asking out of a patient with a laminoplasty is a lot less than with lamifusion. You do have to get the hinge side to heal, but that's a relatively small thing.
It's vascular.
It's vascular, yeah. So that's another reason why, again, in a sicker population, if their alignment allows for it, I think about a laminoplasty for that other reason, which is the biological demand of the patient afterwards.
What about the compression at C7 though? Because I heard Dr. Sheppard say C7 is challenging for laminoplasty. They have neck pain.
Well, it's challenging, meaning that people have more neck pain in the first month or two after, but I would certainly not do 7 if it was tight, real tight at 6-7 or 7-1. So I would still do it. I'm just saying, if you don't need to do it, you don't need to say rotely, I have to always do 3 for 7. A lot of times, your tightest levels are 4, 5, and 5, 6. If that's the case, you can do a 3 for 6 or something like that. You don't have to always do 3 through 7. There's some stuff in the literature that people said, oh, you should do all the levels. I don't think that's the case.
You don't have to do it in this. You dome 7 and you got it all decompressed.
Yeah.
The reason I was asking if you do it at your institution is because if when I trained, I did 0 laminoplasty. I didn't even know how to do one when I came out of fellowship. And so I hated laminoplasty because I didn't know how to do it. And then actually have Adam Scheimer to thank for it, who learned it from you. He was my co-fellow who said, you ought to try this laminoplasty thing out. It's pretty awesome. So I did it. And then as I did more and more, I love laminoplasty now. So as somebody that knows how to do both, I generally gravitate towards laminoplasty. And I always wonder if it's people that don't truly know how to do a laminoplasty that hate laminoplasty. And I think a good example of that is Zoe Gogowala's paper, the 2021 JAMA paper. They look comparing plasty with fusion. 24 surgeons, randomized controlled trial. A lot of them did not do fusion because only 8 actually did laminoplasty. So I thought that was very interesting.
One of the things just to add to that is that we had a requirement in the trial that you had to submit 10 laminoplasty cases. We had a requirement in the trial that in order to randomize patients and to do laminoplasties, you had to submit 10 cases done in the last year. So you not only had to know how to do it, but you had to do a fair number, and so that was the reason for that. But I think it is true that, and I certainly don't have the statistics behind it, but there's a lot of fellowship trained spine surgeons who don't really train on doing laminoplasty, and that probably should change.